patient was a 32-year-old gentleman. He presented with a swelling over the left upper eyelid with forward protrusion of the eye, which was gradually increasing since the past 2 years. He had a long-standing history of multiple procedures having been performed in the past. He had an eyelid lesion excision 5 years ago, which was the first surgery. We can see the scar labeled 1. The histopathology mentioned queric lesion. The second major surgery underwent was a frontal craniotomy 4 years ago. The histopathology mentioned granulomatous multinucleated giant cell reaction of fungal etiology, but however, no systemic treatment was given to the patient. The patient was lost to follow-up for a while after that. Then finally, he presented to us 2 years later with this kind of picture. He had a left significant hypoglobus, abaxial proptosis, and severe ptosis. He also had -5 elevation limitation on the left side and a pre-existing lag of thalamus of 2 millimeters. His vision, color vision, anterior segment were all normal. He only had choroidal folds on the left side on retinal examination. A CT scan was performed, which revealed this kind of large, ill-defined lesion in the left superior and temporal orbit, extending from the anterior to mid-orbit with frontal sinus involvement, erosion of the bony roof, as we can see, and part of the zygoma as well. We asked for a contrast-enhanced MRI as well because we wanted to see the soft tissue details better, and we saw that the lesion was enhancing on contrast, extending into the cranial cavity with a possible dural breach. And we also saw that right ethmoidal and frontal sinuses were full. So what was our plan? We thought we should involve the neurosurgeon as well as the ENT surgeon in this case. So we planned a craniotomy with frontal, orbital and temporal debulking and sinus debridement. A terional or frontotemporal craniotomy was performed, which allowed us wide access to the anterior cranial fossa, the frontal sinus, superotemporal orbit and the temporal fossa. Intraoperatively, because we entered through the cranium, immediately we saw the lesion, and as you can see, the brain is marked, and we can see that the lesion is seen infiltrating the dura in a focal area. Apart from that, of course, there was extensive lesion and devitalized tissue involving the entire left frontal sinus, superior and superotemporal orbit, lacrimal gland, which was found to be majoritarily involved, and so it had to be sacrificed. About 80% of it had to be sacrificed. Zygoma and temporal fossa also. So at the end of the case, fascia lata was harvested to cover the dural defect, and a steel mesh was placed to cover the bony defect of the frontal bone, which also had to be removed because of infiltration. First day post-operatively, the patient was doing well. However, he had eyelid edema and complete ptosis. He had movement limitation. Pupils were completely normal. This was a bedside examination, so exact vision had not been taken, but 2 weeks post-operatively, his vision was 6/6. He, of course, still had ptosis. Movement limitation was improving. By now, we had a histopathology and microbiology reports as well. Histopathology showed septate fungal filaments, and on culture, Aspergillus flavus was grown. We then planned him for intraorbital voriconazole depot injections, 0.4 milligrams for 3 consecutive days, and we also started him on oral ketoconazole twice a day for 6 weeks. Following the intraorbital antifungal injections, he was doing well. His vision was 6/9. He had subconjunctival hemorrhage, severe ptosis, and the elevation limitation was approximately the same. However, 6 weeks post-operatively, even though the subconjunctival hemorrhage had resolved, the ptosis had also improved. Movements were status quo, but to our dismay, his vision had become 6/36. Why was this? His fundus and pupillary reactions were completely normal even at this visit. But look at the cornea. The cornea had dense SPKs and the surface was very poor. He was very photophobic. So why did this happen? So first of all, the surgical trauma because of the infiltrated lacrimal gland, which had to be sacrificed, along with voriconazole intraorbital toxicity, is probably the main cause of this kind of aqueous deficiency dry eye that he had. And he also had a pre-existing lag of thalamus, which also added to it and caused an evaporative dry eye as well. So the patient was then started on intensive lubricants, topical steroids, cyclosporin, and eyelid taping was also advised. This was his cornea. I'm just wrapping up. This was his cornea after treatment. He did much better. This was 10 weeks post-operatively. We can see that there is no clinical um, signs or symptoms of any residual lesion. His ptosis is very mild. His movements were not much improved, but primary gaze he was fine. He had no diplopia. However, because he had a little bit of lag of thalamus, we planned that it would be safest for him to have a lateral paramedian permanent arthroplasty. And this is the scans taken, the most recent scans, which shows no residual lesion. The mesh is seen anteriorly, and the roof and zygoma defect is still persisting. So the important features here are that the patient is immunocompetent, and it has been seen in some studies by the RPC group that invasive orbital aspergillosis occurs more commonly in immunocompetent individuals as compared to the usual belief that fungal orbital disease occurs in immunocompromised patients. Here we didn't have any indication of predisposing sinus infection, because when the ENT surgeon debrided the sinus mucosa, nothing was found in that. Voriconazole, of course, there's always that debate whether we should give intraorbital or intravenous route. Here the patient had a long and indolent course, which is very suggestive of fungal disease, and of course multiple recurrences, which is a sign of residual disease. So I would just like to end by saying that a multidisciplinary approach is very, very important in these kinds of complex cases, and only surgical debridement is not enough. We have to give antifungal treatment, whether it's IV or oral or depot, and of course orbital antifungal toxicity is something we have to look out for. Thank you.
I'll request all the participants to please stick to the time because it's a complicated session. So, what could be the possible route of infection in this patient?
That is a good question, sir, because we also wanted to, we were trying to look at it, but since he had a long-standing history, and this is the first time he came to us, he had visited multiple other places before, so we couldn't pinpoint the cause of this problem. And not only that, because his symptoms started in and around the periocular area, I cannot even say for sure that it started in the sinuses, because there was no histopathological evidence of any sinus infection. So the frontal sinus which was involved, of course, that it seems that the orbital disease would have then gradually progressed towards the frontal sinus. So I cannot say for sure in this patient, but and he had no history of trauma either. So this is something that I won't be able to comment upon.